Everyone. I feel really blessed to stand here in front of you today. I was truly amazed yesterday to see this amazing foundation, and I'm happy to be a part of. So today, the topic of our lecture is pregnancy and childbirth in women with Glanzmann. So a brief introduction. Glanzmann is a rare inherited platelet disorder caused by quantitative or qualitative defect in the alpha-2b beta-3 receptor, which belong to the integrin receptors family. There are two genes which encode to the two subunits which constitute this receptor. The first gene is called ITGA2B, and the second one is called ITGB3. Bleeding manifestation in Glanzmann, as you well know, vary significantly, ranging from easy bruising to life-threatening hemorrhage. This is a picture of the receptor, alpha-2b beta-3 receptor, with the two subunits in blue and in red, with the both extracellular and intracellular part that constitute this receptor. And this receptor has a critical role in platelet function. As can you see here, between receptors of different platelets, fibrinogen binds on one side to one platelet using this receptor and to another receptor on the other platelets, thereby involving platelet aggregation and platelet activation. And this is the critical role of this receptor, which is the most common receptor found on platelets. Glanzmann can be classified into two subtypes, and it will have an importance later on when we discuss the implication during pregnancy. The first two subtypes involve reduced expression of the receptor, meaning quantitative defect. The type 1, which is the most common, comprising 75% of all cases, the level of expression of receptor is below 5%. In type 2, which again is also involved quantitative defect, the level of expression is between 5 to 20%. And the third subtype is the qualitative defect, meaning the function of the receptor is abnormal, while the level of expression, the number of receptor, is normal, and this comprises 10% of all cases. In 2019, the World Foundation of Hemophilia estimated there is at least close to 1,900 women with Glanzmann worldwide. Recurrence of severe uterine bleeding, either as menorrhagia and either as menometrorrhagia, meaning that bleeding that occurs between menses. This is what causes women to use continuing long-term hormonal therapy. But when bleeding occurs, when this hormonal therapy is discontinued, creates difficulties when trying to conceive. That's why pregnancy in women with Glanzmann is therefore rare. And literature is currently based on small case series and scattered case reports. And we will try during this lecture to go through the time course of pregnancy throughout the different phases that I will show later on. As part of the introduction, I wanted to highlight that women with Glanzmann who wish to be pregnant, first of all, should be counseled appropriately and followed at a tertiary care hospital with a dedicated multidisciplinary team. And the components of this multidisciplinary team I mentioned here should include an hematologist, an OBGYN or maternal fetal medicine specialist, geneticist, transfusion medicine specialist, pediatrician or neonatologist, psychologist, laboratory specialist, and pharmacist. All of these components are important for having a successful pregnancy in women with Glanzmann, which is possible. So the time course that we will go throughout this lecture today starts from the pre-pregnancy period, the pregnancy itself, the delivery, and the postpartum period. So we'll start with the pre-pregnancy period. Ideally, thorough evaluation should be carried prior to pregnancy. And the components that we will go through, each of them include genetic evaluation, laboratory evaluation, and medical evaluation. So starting with genetic evaluation, we mentioned before the two genes involved in Glanzmann, and screening for the pathogenic variants, meaning the mutation in the genes involved, is crucial for genetic counseling prior to pregnancy and also during pregnancy, as we will see later on. This has implication for the risk of immunization, and you will hear me say the word immunization throughout this lecture. So just to explain what is immunization, this is one of the main complications that we look for and follow during pregnancy in women with Glanzmann, in which the woman is exposed to fetal cells or products of fetal cells that found themselves throughout the placenta into the maternal blood. And when the maternal immune system sees these fetal cells, there is an immune response. And as women with Glanzmann do not have, in most cases, do not have the receptor for alpha-2 b beta-3, and the fetus, in most cases, in cases that the fetus does not have Glanzmann, has at least one copy of this receptor, the woman develops an immune response, okay? And this immune response involves the production of antibodies against this receptor because the mother does not contain this antigen, this protein, in her repertoire. And that's why these antibodies, if they develop against this alpha-2 b receptor, these antibodies can cross the placenta and get into the fetal circulation and attack the fetal platelets. And when these antibodies attack the fetal platelets, it reduces the fetal platelet count and can cause intracranial hemorrhage. This is the most fearful complication, and you will hear me say immunization during my lecture. This is what we call immunization. So the risk of immunization is most commonly occurs in type 1 disease. Again, type 1 disease is a subtype which involves the level of expression of the receptor under 5%, quantitative defect, and particularly with subset of mutations that we call premature termination variants. There are different types of mutations that can cause Glanzmann. This type of mutation, when we look at the gene that from which the receptor is supposed to be translated from, produced from, this type of mutation causes that the protein, the translation stops at an early point. So this is another risk factor for platelet immunization, for the production of this antibody. The other implication of knowing the pathogenic mutations in Glanzmann patients is for prenatal diagnosis. Prenatal diagnosis is procedure that we carry during pregnancy to evaluate genetic disorders. This either involves chorionic villus sampling, CVS, or amniocentesis, and we will discuss later on the role of each of these two modalities in women with Glanzmann. In addition, in cases of consanguinity and specific populations such as Iraqi Jews, Palestinians, and Jordanian Arabs, in all of these cases, mutation for Glanzmann and carriers are not uncommon. Therefore, in this population, heterozygous screening, looking for the partner and screening for the partner which is completely healthy and looking whether he is heterozygous, meaning has one abnormal copy of the Glanzmann, one of the two genes that involve in Glanzmann, should be carried. This is very important. So in couples where the woman has Glanzmann and the male partner has one abnormal gene, what makes him heterozygous carrier, there is a chance of 50% that the baby will have Glanzmann. Therefore, it's highly important where in all the settings that I mentioned to screen the partner as well. And in such cases, when there is 50% risk of the baby of having Glanzmann itself, the options are, prior to pregnancy, performing in vitro fertilization with pre-implantation genetic diagnosis. These terms sound a little bit troublesome, but in vitro fertilization, we are able to use hormonal treatment prior to pregnancy and produce oocytes from the mother and from the partner to use his sperm and perform fertilization in the lab. And in the lab, after producing embryos, we can look for the embryos that do not contain two abnormal genes of Glanzmann. Because in these cases, as I mentioned, 50% of all the embryos that will be created will have two abnormal copies. And therefore, in the lab, we are now able, like in many other genetic disorders, to find the embryos that do contain only one abnormal gene or do not contain abnormal gene at all. In this case, they will have at least one copy. And those embryos that contain both abnormal genes, if the couple wish to pursue this option, we are able in this case to discard the embryos that are abnormal and use and transfer only the embryos which are not. Is that clear? In couples who do not want to pursue this option during pregnancy, and we will discuss later on how we do that, there is the option of performing prenatal diagnosis, again, either through CVS, chorionic villus sampling, or through amniocentesis. And we will discuss the risk of each of these procedures during pregnancy. The second part of the pre-pregnancy counseling includes a laboratory evaluation. And this includes the characterization of Glanzmann. We will not go into each of the specific possible modalities to do that, but this includes platelet function assays, flow cytometry, and Western blotting. All of these are able to give us characterization of Glanzmann, and sometimes they complement each other. A second part, as I mentioned, which is highly critical, we mentioned immunization, the development of antibodies in the mother towards the fetus, alpha-2 beta-3 antibodies against this receptor, and we are able to detect the presence of this antibody. The method that we do it today is called MIPA, that's the name of this method. As I mentioned before, in most cases, we don't know the risk factors for platelet immunization. We mentioned the type 1 and specific mutation may increase the risk, but it's critical to evaluate prior to pregnancy whether or not these antibodies are present. In addition, another type of antibodies that may develop is anti-HLA antibodies. HLA is another type of protein that appear on every cell of our body and also on platelets. And sometimes, especially in mothers who received previously platelet transfusion, they may develop antibodies against specific types of HLAs, these specific proteins. It does not increase the risk as currently as we know, does not have a significant role in causing the effect on the fetus, meaning it does not probably causing thrombocytopenia, low platelet count in the fetus, and increases the risk for hemorrhage in the fetus, but it may affect, of course, the response to platelet transfusions. In addition, because of the risk of bleeding, already in this time point prior to pregnancy, it is important to perform full anemia screening, which include hemoglobin levels, MCV levels, which reflect the size of the red blood cells, ferritin levels, which reflect the iron stores, how much stores of iron we have, the serum iron itself, how much iron we have in the circulation, and folic acid and B12. All of these are building blocks that serve for having normal hemoglobin levels, and it's critical to address any deficiencies prior to pregnancy in case that bleeding occurs later on. In addition, like in every other pregnancy, there is routine evaluation that we recommend in every couple. These include genetic screening of the couple for many other disorders that do not have any relation with Glanzmann, blood typing and Coombs, fasting glucose level, coagulation studies which include PT and PTT, serology to different pathogens which include HIV, HBV, HCV, both toxoplasma, CMV, varicella zoster. All of these pathogens are pathogens that we were able to test the serology prior to pregnancy and address it appropriately. Also urine analysis and pap smear, which is serving us to perform screening for human papillomavirus, HPV, with or without cytology. We can now do it with PCR alone. Mm-hmm. The third part of the pre-pregnancy evaluation includes medical evaluation. The first part of this medical evaluation includes hematologic consultation with thorough anamnesis regarding the bleeding history, which bleeding episodes occurred in the past, what was the management of each of these episodes, any prior use of recombinant factor 7, and any platelet transfusion given in the past. This is critical in order to get evaluation of the risk for bleeding during pregnancy, with particular emphasis on prior bleeding history that relates to menstruation, and if this woman had prior pregnancy, were there any bleeding episodes during pregnancy itself. The second part is the ENT evaluation, ear, nose, and throat. Of course, we know that bleeding, especially epistaxis, is very common. So therefore, there is also need to address any other problems prior to pregnancy in this field as well. And the third part is dental evaluation. Again, if there are any dental issues that should be carried, it's ideally should be performed prior to pregnancy and not handling these issues during pregnancy itself. So what about gynecology and obstetrics evaluation, which is why we are doing this talk today. So in a prior survey that was published in 2020 among 26 women with Glanzmann, it was cited that many struggled to find a gynecologist with some knowledge of the management of menstruation, pregnancy, and childbirth. So besides the need for education of the patient itself, there is high need for education of the staff as well. So the gynecology and obstetric evaluation carried prior to pregnancy should include an anamnesis which reflects any of the following issues. First of all, prior pregnancy outcomes, if any, and related bleeding that occurs related to any of these pregnancies. Any miscarriages that carried in the past, and how were they handled, and were there any bleeding following these miscarriages. Postpartum hemorrhage following any deliveries or miscarriages. And another important role is to evaluate fertility prior to pregnancy. And I will explain what I mean. As we mentioned before, these women are usually on long-term hormonal therapy. And when this hormonal therapy is discontinued, these women are exposed to high risk of menstrual bleeding, which can be significant. And in order to avoid long-term exposure to heavy menstrual bleeding when this hormonal therapy is discontinued, because in order to conceive, we have to stop this hormonal treatment, we have to make sure that we're letting this woman, stop this hormonal therapy, but we have to make sure that we letting her conceive, knowing that the chances of conceiving are like in the general population. Because otherwise, if there is any infertility in the background, it is not wise to tell the woman, stop hormonal therapy and trying to conceive when there is an issue that we need to address. So in general, this fertility evaluation should be basic and include a hormonal profile in the mother, along with ultrasound and ovarian reserve evaluation. We can now know how many reserves we have in the ovaries. This can be done either through blood test or ultrasound evaluation, and in the partner, spermogram to evaluate the adequacy of the sperm count and quality. And in any other cases when there is suspicion for infertility, of course, this evaluation should be expanded. This is just the basic fertility evaluation that can be carried and should be carried prior to pregnancy. And following the completion of this evaluation that we elaborated on, we're reaching a point when we need to perform risk stratification. And this simple algorithm shows that if there is infertility, of course, as we mentioned, further evaluation should be carried prior to determining the risk stratification. In women at low risk, proper counseling about the risk for the mother and the fetus should be given. Cessation of hormonal therapy, as we mentioned, in order to allow the woman to conceive. And these cases can be reassured that with proper high-risk pregnancy management, pregnancy can be carried successfully. High-risk population of women with Glanzmann includes specifically women with prior pregnancy which ended in life-threatening postpartum hemorrhage, or women who had a prior fetus or sibling, live-born sibling, that had intracranial hemorrhage. As we mentioned before, these cases that involve platelet immunization, the passage of antibodies throughout the placenta that can cause in the fetus to have both thrombocytopenia and intracranial hemorrhage. And in these high-risk women, they're supposed to be, in order to reach the final and adequate conclusion, a multidisciplinary decision in which one of the three options is possible, either supporting pregnancy, again with a proper high-risk pregnancy follow-up, advice against, and another possibility is suggest postponing pregnancy. In some cases where there is high level of antibodies, throughout time, the titer, the level of these antibodies can go down. And in these cases, the risk may be lower. We don't have a lot of literature to support that, but in some cases, this can be recommended as well. During the attempts of conceiving, again, after withholding hormonal therapy, menstrual bleeding, if the woman do not become pregnant, can occur. And the management of this menstrual bleeding without reintroducing the hormonal therapy should include tranexamic acid. And in type 2 disease, type 2 Glanzmann disease, we can use nasal DDAVP. And of course, in severe cases, Nova-7 could be added. It also should be mentioned, besides menstrual bleeding, we have a rare bleeding syndrome in which the corpus luteum in the part of the ovary where the oocyte came out from. And this type of bleeding can occur and be contained in the ovary itself, but it can also, in severe cases, to bleed into the abdomen, what we call intraperitoneal bleeding. This is a rare complication. We see it in other bleeding disorders. I could not find reports of women with Glanzmann having it, but it may relate to the rarity of this condition and the rarity of Glanzmann, of course. And this should be remembered because this bleeding does not occur during menses. It occurs during the mid-cycle, around 14 days, around the time of ovulation. And this should be remembered. And in some cases, if this occurs, this should be looked for. So now we will move on to discuss the pregnancy period. Any question up till now about this, the first part of the preconception counseling? Yes. Yes. The DDAVP is desmopressin, which causes the release of another coagulation factor called von Willebrand factor from endothelial cells. And it was shown to have some benefit in type 2 Glanzmann disease, that they have moderate expression of the receptor between 5 to 20%. In type 1, it does not have a role. And this type of modality is not used now very frequently now that Nova-7 is available, because there are other side effects that this medication can cause. That's why this became much less popular from the time that Nova-7 became available. Okay, we will move to the pregnancy period, what we call the antepartum course. Sorry, I missed a question? No.
I can question regarding the mid-cycle,
Corpus luteum hemorrhage, yes.
it doesn't like within the ovary. How frequently? What did that do?
So every woman has a corpus luteum hemorrhage during every cycle. Usually it's contained, and if there is no bleeding history and bleeding disorder in the background, this bleeding will be contained. Always there is a bleeding when the oocyte comes out from the ovary. In women with bleeding disorders, this bleeding cannot be contained sometimes and then bleed into the abdomen. The topics to discuss during the pregnancy period itself include, as we mentioned before, antiplatelet immunization, the occurrence of antibodies against the receptor, against the alpha-2 beta-3 receptor, the occurrence of other adverse pregnancy outcomes, including the occurrence of bleeding during pregnancy, what we call antepartum bleeding, and the issue of prenatal diagnosis, as we mentioned before, both chorionic villus sampling and amniotic test. So we'll start with antiplatelet immunization that we briefly discussed before. The presence of these antibodies we mentioned before should be tested prior to pregnancy to evaluate the risk. And also during pregnancy itself, we test for the presence of these antibodies whether they occurred, whether they developed, and we do it at least monthly. That's the current recommendation, which again is based on expert opinion. There are no randomized controlled trials to support it, but that's what we do in order to make sure that when these antibodies develop, we are able to detect, and we will mention the modalities of treatment that we have to reduce the risk that these antibodies cause. And the major potential effect on the offspring, and as we mentioned, it can occur either in the fetus, in utero, during the time of pregnancy itself, or following birth. These antibodies can cross the placenta into the fetal circulation, reduce the fetal platelet count, and increase the risk of bleeding in the fetus. And the most fearful bleeding complication in the fetus is intracranial hemorrhage. That's why, again, we measure the level of these antibodies and their presence during pregnancy at least monthly. And I just showed, in order to show the paucity of literature in this regard, several articles that looked at the presence of these antibodies and the risk for thrombocytopenia. This is a systematic review published in Hemophilia Journal in 2011. They included 40 pregnancies in 35 women, including one set of twins. There were overall 38 live births, which I think is very reassuring to show the high live births in these women. And unfortunately, thrombocytopenia, the level of platelet count, was measured in only 5 cases. And 3 out of these 5 cases had, in fact, neonatal thrombocytopenia. The other pregnancy, there were 2 late pregnancy losses after 10 weeks of gestation, and 1 neonatal death. And what's important and highlights the role of these antibodies is in all of these 3 cases that did not end in live birth, in all of them, there was presence of antibodies against alpha-2 beta-3 and intracranial hemorrhage in the fetus, of course. This is another study. This is a group from Sheba, from Israel, and they looked at 9 neonates, mothers with Glanzmann, and in all of these 9 neonates, they measured the platelet count, and 3 of these 9 neonates had severe thrombocytopenia. In their case, fortunately, there were no intracranial hemorrhage in none of these neonates. So, besides measuring the level of antibodies against alpha-2 beta-3, we also measure another types of antibodies, which usually occurs in women who received prior platelet transfusion, and this is against anti-HLA, another protein that appears on platelets. It will not increase the risk of the fetus, probably. It has minimal significance in that regard, but it can have effect on the response to platelets if there is need to transfuse platelets during pregnancy. So in cases that these antibodies do develop, what do we do? How we reduce the risk of the fetus of having low platelet count and bleeding? So there's another condition outside of the world of Glanzmann that we called fetal neonatal alloimmune thrombocytopenia. This is another setting that most of these recommendations that we use for Glanzmann patient, we rely on. And what's similar in this condition is also that in this condition, antibodies develop in the mother toward a different protein in the placenta. This protein, this part of protein is also, it's part of this receptor involved in Glanzmann. And these antibodies, again, also in the other condition, can cause thrombocytopenia, low platelet count in the offspring, and intracranial hemorrhage. It's also a rare condition, but we have randomized control trials even in this rare condition, which is still more common than Glanzmann. And most of these recommendations that you will see here are based on the experience that we have with that condition. So the treatment in order to reduce the effect of these antibodies include 2 main modalities. One is called IVIG, which is a concentrate of type of antibodies, which we call IgG. The specific mechanisms through which this IVIG works is complicated and not completely understood. And this can be combined with another medication that you all know called corticosteroids. So if this woman with Glanzmann has a prior sibling, a prior offspring who had intracranial hemorrhage, treatment with IVIG, usually with steroids in these cases, is given from 12 to 16 weeks. This is a treatment that the IVIG is given intravenously, and the corticosteroids can be given orally. In the other cases, when there is previous sibling who had low platelet count thrombocytopenia, but did not have bleeding, in these cases, we will administer treatment from 20 weeks. This is less severe cases. In other cases, when there is no prior history of a neonate with thrombocytopenia or bleeding, maybe this is the first pregnancy of this woman, but when we follow the level of these antibodies during pregnancy, we see high levels. High level is when at least twofold above the control group. And when this high level of antibodies is detected, again, treatment should be administered from around 20 weeks. It is controversial whether or not women who had no antibodies but are at high risk of immunization, meaning, again, those with type 1, as we mentioned before, those with very low level of expression, below 5% of the receptor, and also specific mutation that we mentioned before that may increase the risk of these antibodies to develop. And also some would say that family history, if a patient with Glanzmann has another person in the history, another female patient in the family that developed these antibodies, this may be a risk factor as well. So whether or not in this all high-risk group of patients, even without the presence of antibodies, just because of the high risk of developing these antibodies, treatment with IVIG should be given. This is a controversial issue. It is currently not recommended. This is what we call prophylactic approach. So it is still not standard of care to administer treatment when these antibodies are not detected, are just at high risk of their development. Besides testing the level of antibodies, another important evaluation that we carry during pregnancy is looking at the fetal brain. During ultrasound evaluation, it is very easy to look at the fetal brain and see whether or not we see any abnormalities. And this complements our evaluation of the antibodies to see whether or not there is intracranial bleeding in the fetus, because when bleeding occurs, it can also occur during pregnancy itself, not only after delivery. The second part of the pregnancy course that I would like to highlight is the occurrence of adverse pregnancy outcomes, including bleeding. So fortunately, there is no known increased risk of other adverse pregnancy outcomes in women with Glanzmann. This includes the risk of pregnancy loss. There is also no increased risk of placenta-mediated complications. This includes preeclampsia, fetal growth restrictions, stillbirth. All of these are not known to have an increased risk in women with Glanzmann, which is very reassuring. But it's worth noting that in women where there is an indication for aspirin, like women who had prior history of preeclampsia or had other risks for preeclampsia, in which we give aspirin as prophylactic treatment. Of course, in women with Glanzmann, this kind of treatment is contraindicated, as well as other antithrombotic agents. However, when complications do occur, such as miscarriage, ectopic pregnancy, all these require careful management. In case of miscarriage, DNC, dilatation and curettage, and manual vacuum aspiration, these are all modalities, operative modalities that we use in order to manage miscarriage, and these are preferred over medical management. We can manage in other women miscarriage using different types of medication that are given either orally or vaginally, but in patients with Glanzmann, the control of bleeding can be very difficult when we use these medical treatments, and therefore in women with Glanzmann, we would prefer these operative modalities. Also in ectopic pregnancy can also be managed in the general population with medical treatment, a treatment that we call methotrexate, versus a surgical treatment where we usually, remove one of the tubes. So again, in women with Glanzmann, there is possible advantage to pursue the surgical treatment and not the medical treatment, because the medical treatment can cause life-threatening and unexpected bleeding in many cases. And then you have to run to the operation room to perform the surgical treatment that you could have done in the first place in a more elective or semi-elective way. In the absence of trauma, the risk of having pregnancy-related bleeding is low, and this is also very reassuring to know. In all of these cases, either miscarriage, ectopic pregnancy, and bleeding that occur during pregnancy, the decision what is the best, the optimal hemostatic coverage, meaning which type of treatment should we give, this should be the decision regarding that should be made on a case-by-case basis, again, in a multidisciplinary fashion. And we have, this is another fact that worth noting, that women who use tranexamic acid, during early pregnancy, during the first trimester, we have limited data regarding the use of tranexamic acid. We still use it, but not as a routine treatment that we can give during every day. So in the case of bleeding, of course, we're going to use tranexamic acid, but it cannot be administered routinely during the first trimester because of lack of safety data. The third part of the antepartum course includes the prenatal diagnosis. We mentioned before that in case that the partner has also one abnormal gene for Glanzmann, what we call heterozygote partner, or where there are other general obstetric indication in which we would recommend evaluation, genetic evaluation. This includes CVS, chorionic villus sampling, and amniocentesis. In both of these cases, these modalities entail risk of bleeding, of course. But it should be remembered that in amniocentesis, there is possible reduced risk of, during the procedure itself, it can cause immunization. Again, the development of antibodies in the mother, meaning only the procedure itself can cause immunization. And we know that this risk is reduced in amniocentesis as compared to chorionic villus sampling. And also the risk of bleeding and pregnancy loss is significantly lower in amniocentesis versus chorionic villus sampling. And that's why prenatal diagnosis is pursued, amniocentesis is preferred. In general, we will try to avoid any of these modalities, of course, because of the bleeding risk. But in case of the heterozygous partner, again, a partner that has one abnormal gene, knowing whether the offspring has Glanzmann, meaning is affected having two abnormal genes, this is important for deciding the mode of delivery. Because if the offspring has Glanzmann, the optimal mode of delivery is cesarean delivery and not undergoing a trial of vaginal delivery, and we'll mention it later on. So again, the fact that the baby has two genes with mutation known to cause Glanzmann can affect the mode of delivery. We, in the setting of the other condition that I mentioned before, called neonatal fetal alloimmune thrombocytopenia, which antibodies develop against other part of the receptor, we now have the possibility of performing a specific blood test. This is called non-invasive prenatal testing, and evaluate whether or not the offspring has this specific type of protein. This is not being carried in Glanzmann, but the technology is definitely there and could be applied also in Glanzmann as well to evaluate whether or not the fetus is affected, and I'm sure it will appear later on. So now we will discuss delivery. So ideally, the general principles that apply to delivery, again, says that tertiary care with experienced multidisciplinary team should handle delivery of women with Glanzmann. And there's supposed to be adequate preparation prior to delivery with a clear plan with different scenarios in a case of an emergency situation. There should also be a rapid on-site access to each of the following: blood products with massive transfusion facilities, specialized laboratory tests that may have an important role in management of these complications, interventional radiologist and vascular surgeon, adult intensive care unit, and intraoperative blood salvage, what we call cell saver, that we can use blood and give it back to the patient. in general, when we dictate what's the optimal mode of delivery for women with Glanzmann, cesarean delivery is not generally indicated, particularly when the antibodies that we mentioned before do not develop, meaning there is no presence of this antibody. When we still need to consider cesarean delivery in each of the following scenarios, there are general obstetric indication, for example, breech presentation, risk for a thrombocytopenic offspring, meaning, again, in case that the mother did develop these antibodies, and we know that these antibodies can cause thrombocytopenia in the fetus. In many of these cases, when we fear that the baby would have low platelet count, and we fear that trial of vaginal delivery can cause a risk of bleeding, particularly intracranial hemorrhage. So in these cases, we may recommend cesarean delivery. And the last scenario that we mentioned before, when the offspring is affected by Glanzmann, meaning again that the partner is an heterozygous carrier, is one abnormal copy of the one of the two genes, and we are fearing that the offspring affected by Glanzmann during a trial of vaginal delivery may bleed. Whether or not we pursue cesarean delivery or a trial of vaginal delivery, in order to dictate the time of delivery and ensure that it not occur during weekends or the times or holidays where the hospital is less staffed, so planned cesarean delivery or induction of labor should be considered in order to dictate the time of delivery. In the presence of platelet immunization, again, the presence of antibodies against alpha-2 beta-3, we should avoid several maneuvers that we do during delivery. This includes fetal scalp electrode, when we measure the fetal heart rate using a specific electrode that we can put on the fetal scalp. We cannot do that in women with Glanzmann. Also, scalp blood sampling. In some cases, we want to check the baby's pH to dictate whether or not there is any distress during delivery. So we cannot do that as well. And also, vacuum delivery is also modality that we will not be using in case that there is presence of antibodies. In general, no relation was found between the mode of delivery, meaning cesarean versus vaginal, and the risk of bleeding in the mother, and therefore, in general, cesarean delivery is not indicated for all women with Glanzmann, just in the scenarios that we elaborated on. Neuraxial anesthesia, which include epidural and spinal anesthesia, is contraindicated in women with Glanzmann. So in case a vaginal delivery is pursued, there is an option for intravenous analgesia as a substitute. In case a cesarean delivery is performed, the option would be general anesthesia. And of course, the decision regarding the optimal mode of anesthesia, again, should be discussed prior to delivery with a multidisciplinary team, obviously involving the anesthesiologist. What is the risk of bleeding? So the risk of postpartum hemorrhage is significant. Even despite prophylactic treatment given, data from the cases that we currently have is the risk about 40 to 50%, which is a high rate. We know that history of bleeding, particularly bleeding that relates to postpartum hemorrhage or bleeding during miscarriage, we know that's a strong risk factor for having another postpartum hemorrhage. And if the factors that we need to consider in this regard are two: prior refractoriness to platelet transfusion, meaning women that received platelets in the past, but with no adequate increment in the platelet count, and also the presence of platelet immunization. We mentioned that the antibodies can reduce the effect of platelets when given. This includes both the antibodies against alpha-2 beta-3 and also antibodies against HLA. So what are the general measures taken in the mothers in preparation to delivery and around delivery? So routine administration of tranexamic acid should be performed along with uterotonic agent that we use in every woman. Of course, during cesarean delivery, meticulous hemostatic management, trying to stop every little bleed that we see, that in women from the general population, sometimes this bleeding stops spontaneously during surgery. In women with Glanzmann, we will stop every bleeding the moment that we see it. In women who try vaginal delivery and successfully deliver, there should be careful evaluation of any lacerations in the vagina or the perineum. Urine output should be evaluated carefully because we know that's a good sign of the hemostatic balance in these women during delivery and whether or not there is bleeding that we are not aware of. Factor 7, Nova 7, is routinely given either in the second stage of labor, which is the time from full dilation, or immediately after cord clamping. And in case of cesarean section, it will be given right before the procedure. And on all of these cases, ideally, even if we will not use it, platelets should be prepared prior to delivery and prepared. And ideally, these platelets should be HLA matched, as I mentioned before, in particular in women that may have antibodies against this HLA, and also women who don't have antibodies and we don't want them to have these antibodies. Ideally, HLA platelets should be prepared. So what about the neonate? What about the offspring? So right after delivery, we take some blood from the cord in order to check for the platelet count and make sure that the platelet count in the baby is normal. We also going to be measuring the platelet count in the baby for 3 to 5 days because sometimes the minimal platelet count can appear only after a few days and not during the time of delivery. And if the baby platelet count is low, what we call thrombocytopenia, the treatment is platelet transfusion with or without the treatment that we mentioned before that we sometimes use in the mother, IVIG, which is a concentrate of intravenously given antibodies of IgG type. In neonates who have low platelet count, besides looking at the platelet count, we also look at the brain following delivery using ultrasound, and this should be performed within 24 hours of delivery in case where the baby has thrombocytopenia. In all neonates in the general population, because of the risk of bleeding, we administer vitamin K, and it should be remembered that in these cases where the risk of thrombocytopenia, this vitamin K, when we usually give it intramuscularly, we will not be given it in these cases intramuscularly, but we will give it orally instead to the baby in order to avoid the risk of bleeding in the baby. What about the postpartum course? So it should be remembered that besides the PPH, the postpartum hemorrhage that can occur early after delivery, meaning in the first day after delivery, late PPH, which is around beyond 24 hours after delivery and can up to 6 weeks following delivery, it can still occur. In fact, in the meta-analysis that I mentioned before, late PPH was more common and the median time to presentation was 10 days after delivery and occurring in 1/4 of all women. And that's why in women with Glanzmann who delivered, we will usually administer tranexamic acid orally for between 1 to 2 weeks after delivery, depends on the scenario, whether or not it was vaginal versus cesarean delivery, were there any bleeding episodes, but tranexamic acid will be given routinely for this time period. In addition, as I mentioned before, in order to treat any anemia, and every woman has some degree of anemia following delivery, we will administer oral iron supplementation. And of course, when anemia is prominent, this iron can be given intravenously. And the first follow-up visit should be earlier than what we usually, it should be already 3-week follow-up visit with complete blood count and iron status. And we will again measure whether or not antibodies develop also in the postpartum period, 6 weeks following delivery, because sometimes immunization, the development of antibodies in the mother, can occur around the time of delivery, and we have to make sure whether or not it happened or not. What about breastfeeding? So breastfeeding is allowed and not contraindicated in women with Glanzmann, but it should be remembered, and this applies to women where the neonate has low platelet count, that we know from another medical condition called ITP, immune thrombocytopenia purpura, which is another scenario in which mothers have antibodies that attack her own platelets. And we know in ITP patient and immune thrombocytopenia patients that when the baby has thrombocytopenia, there were reports showing that if thrombocytopenia is persistent, breastfeeding can cause the platelet count not to resolve so quickly. So in cases where in women with Glanzmann, the baby have thrombocytopenia, this should be remembered and looked for if the platelet count does not resolve normally and instead the thrombocytopenia is persistent. What about reintroduction of hormonal therapy after delivery? How we avoid, again, heavy menstrual bleeding to occur? And of course, we need both to allow breastfeeding and also to provide adequate contraception. So among the options in this early postpartum period, it seems that hormonal IUD, hormonal intrauterine device containing the hormone including the type of progesterone, which is called levonorgestrel, it seems like the most preferable option, and I will explain why. In the postpartum period, we have an increased risk of having thrombotic events. This is the highest risk time during pregnancy of having a thrombotic event. And that's why we will not use any hormonal modalities, that contain estrogen. So oral contraception contain estrogen, vaginal ring, hormonal patches, all of these contain estrogen. And IUD or hormonal IUD do not increase this thrombotic risk. In addition, this hormonal IUD can already be inserted during cesarean delivery, or if a woman had vaginal delivery, it can be inserted within days of weeks after delivery. There were some fears that the risk of expulsion of this IUD, of this intrauterine device, may be higher. We now know that after 4 weeks from delivery, there is no increased risk of expulsion. And again, in contrast to other hormonal modalities that contain estrogen, this modality do not interfere with breastfeeding. So you can continue breastfeeding while using this hormonal IUD. And we know that it also had a better efficacy in providing adequate contraception as compared to progesterone-only pills or combined oral contraception pills. So the take-home messages from the talk is that Glanzmann is a high-risk condition requiring multidisciplinary team approach in order to ensure successful pregnancy management. Pre-pregnancy counseling is of utmost importance in order to be prepared and address any issues prior to pregnancy. Screening for the typing of Glanzmann and platelet immunization, again checking for the presence of antibodies, are vital for optimal therapeutic approach for both the mother and the offspring. And is currently high quality data, management should be individualized on a case-by-case basis in a multidisciplinary fashion. Thank you very much. Would like to take any questions? Yes.
It was an excellent presentation.
Thank you.
Very enlightening. I'd like to ask you, how many women with GT have access to this amazing opportunity? Because it happens here in New York, in some great centers, but there are women all over the States that don't have access to all this. And of course, to do IVF and screen embryos and all this prenatal tests and genetic screening, these are costly, and this is another issue. So I'd like to know how you feel about that.
So you are highlighting, of course, a very important problem. Having access to treatment optimal treatment that should be given to these women is, of course, an issue that we struggle with many other rare conditions. Regarding IVF, actually, in women who have medical insurance, in these cases, having IVF and choosing the embryo that do not contain 2 abnormal genes is usually covered because this is a condition that can be preventable. So this can be, and most clinics, and again, that should be in a tertiary care center, are able to do it. And of course, access is a huge issue. I wish we could solve it. Yes, of course. Yes, of course. Yes. So I wish I could have a better answer, but Yes, but you're highlighting a very important point. A good question. A good question. I don't know. I'm sure that there aren't as many as we think, even in the U.S. But I'm sure that we can find for any patient the best way and try to help her. Again, on a case-by-case basis.
Hello again.
Hi. Sorry.
I have a question regarding the genetics.
Yeah.
My husband had GT. He's passed. My daughter has had a lifelong, a variety of different bleeding issues. She's been tested for von Willebrand's. She did not want to be tested for Glanzmann's at the time that we were going through that. She's now thinking she should be tested for Glanzmann's. So I'm wondering if she is a carrier since he had Glanzmann's, and if I don't have one of the genes, as a carrier, she would automatically be a carrier. Would she also have symptoms? All the literature seems to indicate that they don't typically as a carrier.
No. Okay. As being a carrier by itself does not increase the risk of bleeding. But as I mentioned before, if there is any case of consanguinity or in specific ethnic population, when the partner or future partner may be a carrier itself, it would be very important to know whether or not she is a carrier or not.
Okay, I have a couple of questions.
Yes. So come close because the light.
Okay, here, I'll come over here. All right. So my first question is, we did talk about how with the platelets and prophylactically treating, the risk is still 40 to 50%.
Yes.
In my own experience with my little sister, she has never received platelets, but instead receives filtered red cells whenever her hemoglobin gets to a certain point. And we always have platelets on hand if need be, just haven't had that. It's not really a treatment that is heard of very often. And I just kind of want to get your take on that because it does seem to help her. But I also know there are risks when you're doing blood transfusions as well.
So blood transfusion is not a treatment to stop the bleeding.
Mm-hmm.
It will only increase the hemoglobin,
Mm-hmm.
but it's not a solution for bleeding.
Mm-hmm.
So all of these measures, the high risk that we still see in the literature for PPH show that we're not doing good enough. And this relates to the other questions that most of these deliveries occur in facilities that do not have all the optimal management approaches and modality that we should have. So it just shows that we need to improve.
Yeah.
Because with proper evaluation, preparation to delivery, I believe this rate can be much lower.
Okay. And then my second one is egg retrieval. So for a lot of the women who do have type 1 or who have prevalent history of horrible bleeds, or they've had procedures over the years where they just can't naturally carry their own child, what type of risks come along with doing egg retrieval, having those hormones and everything?
So hormonal treatment by itself, the main risk of receiving hormonal treatment is hypercoagulable state, which is in cases of Glanzmann is obviously reduced. So that's in the general population. The risk in Glanzmann patient is the risk of the procedure itself. Usually egg retrieval is done. We're doing it through the vagina. It's a minor procedure. The oocytes are retrieved directly from the ovary, and usually the blood, if there is any bleeding, is contained during the ovary. Of course, when we're doing egg retrieval in women with Glanzmann, we will give prophylactic treatment prior to the procedure, but usually it's a safe procedure.
Okay.
It's not a major surgery.
Mm-hmm. And then also along with that, you were talking about the IUD. After, birth and everything, and you go in and you get it placed and stuff, it's not a fun procedure at all. And it does sometimes end up in a little bit of bleeding and some bleeding afterwards. Do you recommend the normal procedure of inserting an IUD, or do you recommend them possibly?
And that's another advantage of doing it during the hospital stay.
Right.
while acknowledging that if we're doing it during elective cesarean delivery, like that's the easiest way. The woman does not feel a thing. It does not increase the risk of expulsion when you're doing during cesarean delivery. You just place it during the procedure and that's it. After vaginal delivery, it's another advantage of doing it during the hospital stay because the cervix is still dilated. So the procedure is much less harmful. The risk of bleeding is much lower. And also in terms of pain, it's much easier.
Okay. And the last one, I swear. As you mentioned at the beginning, there are not a lot of OBGYNs out there who've managed GT. When discussing pregnancy and everything, not every doctor is open to a patient saying, this is what it said in my community. I have this literature here. And they kind of want to do their own thing and look it up on their own. How would you recommend the best way to navigate having a physician like that and really just kind of making sure that you're working on the same team and working towards the same goal?
So, as I mentioned before, besides patient education, we also should have education of the physician themselves. And I think if we, through the community, can educate also caregivers, meaning including obstetrician, gynecologists, etc., that would be, I think, very contributing. And of course, we have a lot to improve, and I would be happy to help if I can do.
The very great talk. And that last question was what I was going to get at. So we put your name on the Glanzmann website, and let's say I have a doctor in Milwaukee or anywhere in the U.S., we know that some of the centers like Rockefeller in Philadelphia have several Glanzmann patients in a high populated area who treated successfully Glanzmann births from Glanzmann patients. So I know at the Glanzmann website there used to be a list of doctors. So to educate the doctors in towns in cities that don't have an expert like you, we ask if we can put your name on the website and to contact you or other doctors that should be, so they can get educated.
Sure.
Or
sure. Webinars, I would be happy to.
For referrals.
Yeah.
And I think that would be great to start the education, because it's still, you think it's 2023, Glanzmann was discovered in 1918, and it's 100 years later, and we need to increase the knowledge. Thank you so much.
Of course.
So this might be more of a personal question, and please don't answer it if you're not comfortable, but your extensive knowledge in this department is amazing, and we're so grateful to have you here. When did you decide to study Glanzmann and women who...
Why? So before, actually, I'm trained in OBGYN. I'm an obstetrician by training, and I did my fellowship in coagulation prior to my residency in OBGYN. And I was fascinated by the complication of coagulation and bleeding during pregnancy, which much made me doing the residency in OBGYN, and decided to train later on in maternal fetal medicine and focusing on bleeding and thrombotic disorders during pregnancy. So that's my way in a nutshell.
Just
So of the women that had successful births, do you know the majority of what subtype they were? I can't remember if you said it or not.
It was not
for me.
This data was not included in any of these reports, but you can assume that most of them is type 1. I would not say that the decision whether or not to pursue pregnancy was based on the subtyping of pregnancy.
Thank you very much. I have two questions for you. The first one is, for example, my daughter has GT. She's 17. She does not want to have children. But with the IUD in the case, every time she had to place it, the body expel it. So because she was still bleeding, so it go down. So in case of women with a postpartum hemorrhage, if you place the IUD right at birth, might
Usually
have
don't
case.
do it during the time of the bleeding itself.
But what if it starts after? Then you don't know. You would have a chance to go down.
There is a risk of expulsion that, as I mentioned before, is higher than during the time of up to 4 weeks following delivery.
Okay.
But beyond 4 weeks, the risk of expulsion is similar.
Okay.
When there is bleeding, of course, with or without relation to pregnancy, the uterus contracts. And that's why when there is severe bleeding, we wouldn't insert the IUD. Makes no sense. Yeah.
My second question, I am from Brazil, so we have a few cases there. I'm fortunate to have two of my best friends are OBs, and they have dealt with 1 or 2 patients with EGT, which is, extremely rare there as well. Do you have any contacts with any doctors or any, foundation, anything in Brazil that I could talk to those doctors, anything?
I don't know anyone from Brazil, but I would love to know. So
I know. I'm just trying to see if I can help the community. Find someone there that's very knowledgeable, like you are as well, because of the translation of the language as well.
sure,
Thank you. I appreciate it.
of course. Okay. Yes.
You can help it down.
Okay. I'm here to help. So
We are said like,
thank you.
What is the current, I guess, status? I know every is a case-by-case basis, but even just in the last 20 years, 30 years, we're still being told we can't have kids. There's no hope. Just give up. Is there any more hope in the last 20 years of even my generation where we're at the tail end where we can still have kids? Is there hope that we can have kids?
So, in many other chronic conditions, that's a sentence that many women sadly hear from physicians. But I think there was a lot of progress in many chronic conditions, also with the perspective that physicians has towards treating these conditions during pregnancy, women with prior transplant, women with severe liver disease, severe kidney disease. So I think even if you receive a response that you didn't like to hear, or you were not sure it was correct, you should try to find the other doctor that will let you. And sometimes you have to be brave. I wouldn't say to be stupid or arrogant, but you have to know what you are basing your consultation on before making any recommendation.
Thanks. I appreciate your whole talk has been about delivering women with Glanzmanns themselves. If you're just, in inverted commas, a carrier and you're at risk of having a baby with Glanzmanns, would you still do the same kind of care of the baby when it was born? And doing things like scanning, antenatal diagnosis pre-birth?
If the woman, again, what's the scenario? If the woman is a carrier,
She's a carrier and she's
partner
is a carrier and they've already got a child and she's pregnant again, lucky lady.
okay, if the partner is a carrier and the woman is a carrier herself, there is 25% risk of having an affected fetus. So again, that's something that the couple should make a decision whether or not. I think the ideal way is to perform IVF with what we call pre-implantation genetic diagnosis and decide whether or not the embryos are affected or not. But again, every couple have their own beliefs. Some would say, I'm okay with having a baby with Glanzmann, and I think that's terrific. That's their decision. And but I think that's a modality and an option that every couple should be aware that exists. And that's something that has been done for hundreds of genetic disorders. Many of them are much easier to treat than Glanzmann. Yes. Yes. I wouldn't go to a general OB, that's for sure. No, it's not that. That's reality. Of course, the first consultation should be with a maternal fetal medicine specialist. And obviously, if the maternal fetal medicine specialist, what he will do, would refer you and consult himself with a hematologist. That's how it should work. Okay, thank you so much.
Thank you.